So I want you to pay attention here to this lymphatic system really well. So just take a look at this picture. So we did this cardiovascular system. We did this part where we had blood vessels coming out of the heart, which were the arteries, and then they broke up into capillaries, and then blood returned to the heart by means of veins. But some of the blood from the capillaries which pours out, not all of it is returned back to the venous system. Some of it remains in the extracellular tissue spaces. And from there, that blood still has to go back, right? So that blood is what is picked up by the lymphatic vessels. So you can see that they start as blind-ended vessels, and then they pass on towards, they're very similar to veins. So you will see that a lot of features which help venous drainage will help lymphatic vessels. So take a look at this picture, and here let's answer these two questions. So what is the direction of lymph flow? Okay, only, well, half the class got it right, towards the heart. And here's why it's important to pay attention to every slide that you have. Take a look at this picture. See, can you see it's going towards the heart? Can you see from below here going upwards? Look at the direction of lymph flow going towards the heart, right? It has to return whatever is thrown off in the extracellular fluid back to the heart. Which means that next question, and we should all get this right, where does lymph finally drain? So if you looked at that image carefully, you would know. Okay, again, just about half the class got it right, which shows you're not looking at the pictures carefully. It's not draining into arteries. It's not going directly into chambers of the heart. So here's where you take a look at this picture carefully. See this? Can you see there's this big lymph vessel from this side, this lymph vessel? Notice where it's going. It's going into the vein. It's not going, you don't see this going directly into any chamber of the heart. You also don't see it going into the arteries. So this is why it's really, really important to look at images very, very carefully. Okay, so now let's look at the organs in the lymphatic system. And we have two organs which are known as central lymphatic organs. This is where during development, lymphocytes go to get trained. And the word we use when we say lymphocytes get trained is they become what is known as immunocompetent. So it's like, you know, soldiers going to West Point to get trained. They have the potential, but they don't know what to do until you actually tell them what to do. So this is what the thymus, which is one of the central lymphatic organs, and the bone marrow. And when we do immunity, we'll talk more about these two. So in the thymus and bone marrow, which are called central lymphatic organs, this is where lymphocytes in fetal life go to get trained, and that training is known as becoming immunocompetent. The other organs that we see, which are part of the lymphatic system, are the tonsils. Normally, when you think of tonsils and you kind of put your hand over your throat up here and you know, say, oh, my tonsils are enlarged, you're really first of all talking about the palatine tonsil, which when you open your mouth, you know, you can see two kind of swellings at the back of your oral cavity. That's what you're really talking about. And when you put your hand on your throat, you're really not feeling for the tonsils. You're really feeling for lymph nodes which are draining the tonsils, and there's a particular lymph node which is present here in this area where you palpate. If that lymph node is swollen, that just means that you probably had tonsillar infection at some point in time, okay? But the palatine tonsils are not the only tonsils which are present in the body. We have other tonsils which are present. Tonsils are basically lymphatic tissue, or which is also known as tonsillar tissue. So it's lymphatic tissue present as aggregations or swelling, so they make kind of a bulge in areas. So the other tonsillar tissue that you see are lingual tonsils, which we will see, which are present on the surface of the tongue. Anything to do with the tongue, we use the word lingual. Palatine, I already told you, as the name suggests, this is in a part of the pharynx. Then tubal tonsil. Tubal tonsil is seen in relation to the auditory or eustachian tube. That's why it's called tubal tonsil. This is seen on the top. There's as a bulge swelling, tubal tonsil. And pharyngeal tonsil is what is seen on the posterior aspect of your pharynx. Your pharynx is your throat. So if you were to stick your tongue out and look towards the back of your pharynx or throat, you will see that area is kind of ridged. It doesn't look smooth, and that's because of pharyngeal tonsil. And this, when the pharyngeal tonsil is extremely enlarged, this is what is known as adenoids. And you may have heard of this, adenoids. You know, somebody might be saying that I have very big adenoids. My adenoids need to get removed, and that's what really they're talking about. They're talking about the pharyngeal tonsils. So tonsillar tissue consisting of these four main groups, but we also have other tonsillar tissue which are really small, so they don't have any particular name, and they're all over your pharynx. You might find little swellings in those areas. Other organs in lymphatic tissue are lymph nodes. Lymph nodes present all over the body. They drain regional areas, and we see aggregations of lymph nodes in certain areas. For example, you can see here in the axilla. So there are a bunch of lymph nodes present there. So axillary lymph nodes. We see them in the neck as well, up here, the cervical group of lymph nodes. We see them in the groin area here, where they are known as the inguinal group of lymph nodes. A few lymph nodes in relation to your popliteal fossa, the back of your knee, and a lot of lymph nodes kind of aggregated inside your abdominal cavity, which you cannot obviously feel. You know, you have to open up the abdomen and you will see that. But places where you can feel them are in the axilla, the cervical region, and the inguinal group of lymph nodes. Then we have something which are called lymphatic nodules, or another word we often use for nodules is the word follicles. This is lymphatic tissue which is not present by itself. So it's not a structure by itself, but it is present as part of the wall of another organ. For example, in the small intestine is an organ by itself. In the wall of the small intestine, you have certain aggregations of lymphatic tissue which kind of form round structures which are called nodules or follicles. So it's not separate from the small intestine, it's part of the small intestine, so that's why we call them nodules. In the small intestine, they have a special name. They're called Peyer's patches, maybe spelled with an A or just P-E-Y-E-R-S. So they have a special name in the small intestine, Peyer's patches. Or we'll see it in other organs as well. For example, in the trachea, we see it in bronchus, we might see it in the urinary tract, might see it in the reproductive tracts. All of these areas, you might find little sort of round structures called follicles. So they form part of the wall of that organ, but they don't have a special name there. We just call them lymphatic nodules, okay? Then spleen is the largest of the lymphatic organs. Spleen is the largest of the lymphatic organs. We will take a look at that. And then bone marrow, I said, which is, present within long bones and, spongy bones and so on, a central lymphatic organ. The main cells of the lymphatic system are lymphocytes and monocytes. These monocytes get converted into macrophages, and if you remember, macrophages are phagocytic in nature. Lymphocytes, we'll see when we do the immune system, they either produce antibodies or they take part in what is called cell-mediated immunity. So they attack cells and kind of kill them off. Most organs in the body which have a blood supply automatically have a lymphatic drainage, because if you remember when we looked at that first slide, you saw what is lymph. It's basically fluid which has seeped out of blood vessels and gone into the interstitial space and has not gone back into the blood vessels, right? So it's interstitial fluid. So anything which has, any structure which has a blood supply automatically tends to have a lymphatic drainage. Some areas of the body do not have lymphatic drainage, even though they may be having a blood supply. The brain, the central nervous system is one area, doesn't have a lymphatic drainage. The bone marrow is another one. There are no lymph vessels in the bone marrow. And avascular structures like cartilage. Cartilage is avascular, epithelium is avascular. So again, they do not have lymphatic drainage. So lymphatic vessels resemble veins. That's why we say lymphatic drainage, you know, because we remember for veins we use the word drains. And connecting all these lymph nodes with one another are these slender channels, which I'm just talking about, lymphatic vessels, which behave very much like veins, and we'll look at them in a little bit more detail in further slides. Next organ is the thymus. I mean, now we'll start with the organs. The central lymphatic organ, very large until about adolescence. So it's very, very large in childhood. If you look at most cadavers, they are old. You rarely find the thymus. They kind of, it tends to have atrophied because it's done its job. It's made the T lymphocytes immunocompetent, and then it begins to involute or begins to atrophy. So usually seen very large in childhood. It's seen in the neck, the lower part of the neck, and in the thorax. And a certain type of lymphocyte, which we call T lymphocytes, it's called T lymphocyte for this reason, thymus dependent lymphocyte. So when we do immunity, we'll see how T lymphocytes in fetal life come to the thymus, they are trained and become immunocompetent, and they go out into the circulation, populate lymphatic organs, and then they take part in something known as cell-mediated immunity. It produces many hormones, thymopoietin, thymosin. One of the more important ones is thymosin. Okay. Very vascular. Since it's producing hormones, it's also an endocrine gland. It's part of the lymphatic system, but also an endocrine gland. Very, very vascular. Now in ANP2, we do a lot of histology, both in the lab and the lecture. So here's how, if you were to look at a slide of the thymus, this is what it'll be. And if we go back to the previous slide, you can see the thymus is kind of lobed. So usually we say it's a bilobed structure, one lobe here and another lobe here. So if we take a section of the thymus, what you will see is that this is the thymus. It's covered by a capsule, which is made of connective tissue. The capsule sends in little septae which go in. So it kind of breaks it in. It goes in like this. And it divides it into smaller sections which are known as lobules. So the outer capsule sends in septa, breaking up the thymus into smaller sections called lobules. And then histologically, when we see that the thymus has a broad band on the outside. Each of these lobules will have a broad band on the outside. This band is much darker staining because the lymphocytes are aggregated together. They're very close to each other. And if you remember from blood, lymphocytes had a very large nucleus, very little cytoplasm. So usually when you look under the microscope, you can only see the nucleus. So when you have many lymphocytes close to each other with a very prominent nucleus, so you have many lymphocytes very close to each other like this. You can only see the nucleus. You can barely make out the cytoplasm. You can see there then in this part that it'll kind of show up as a broad band, a very darkly staining broad band. This area is known as the cortex. So you can see that up here. So that dark area is called the cortex. Cortex is always peripheral. The central area is much lighter staining because here the lymphocytes are not aggregated together. They are more spread out. So central area is medulla, and you can see the medulla of one lobule kind of goes into the medulla of the other. The cortex is more or less separated. And in the center of of each of these lobules in the medulla, and here if we look at one such lobule, so I'm just looking at this part here like this. So here is a septum made of connective tissue. Here's another septum, connective tissue. So this is the lobule between the two. And here you can see the dark outer cortex, right, like a band. This central area, much lighter staining. And in this medulla, you can see these round pink structures. These pink structures are known as Hassel's corpuscles. They have a special name. They're called Hassel's corpuscles. They signify dead or dying cells which are there in that area. Their function is not extremely well known. So one just conjectures that probably they are made up of dying cells. It's very typical of the thymus. You see a cortex, a medulla, and you see these pink structures called Hassel's corpuscles. And if you kind of look at Hassel's corpuscles under high power, it has what is called an onion peel appearance. So the cells are a Swiss roll. So this is what the cells look like under very high power. So if you cut open an onion, you know how it kind of swirls inside like a Swiss roll. So that's what it looks like, and it gives it a very typical onion peel appearance. Of course, it's pink in color, not blue like this. Okay. Another feature of the thymus is no germinal centers are seen. I will explain what germinal centers are when we kind of look at another slide, but for now just kind of think of it as no germinal centers are seen in the thymus. Let's move to the next lymphatic tissue, which are tonsils. Tonsils are present in the pharynx, the throat. They're not present in your oral cavity. They are present in the throat. And you can't say throat now, you should say pharynx. They're present in the pharynx. And they're like a ring around your pharynx. That ring is known as Waldeyer's ring, after the person who kind of discovered that. This is called Waldeyer's ring. So it's a ring of tonsils or tonsillar tissue in the pharynx. So let's first divide your pharynx into various parts and see what is it that we call the pharynx, and then see where these tonsils are present. So here's a sagittal section of the face. This here is the nasal cavity. This part here is the oral cavity, this whole part here, and this part here is the larynx, okay, as seen from the front. So nasal cavity, oral cavity, this area is the larynx. So if you were to stick your tongue out, what you peep inside and you look at is this area, right, over here at the back, which is what you call your throat, or the back of your throat, or the pharynx. Just behind the nasal cavity, this area here, which is part of the pharynx, is known as nasopharynx because it's behind the nasal cavity. Behind the oral cavity, and in the oral cavity it's well defined. You know, when you stick your tongue out, you will see kind of two pillars coming down. So if you looked at, if somebody opened their mouth like this, on either side you kind of see two pillars coming down, right, like this, and then you can see the tonsils in between them. The first of these pillars is the boundary line between the oral cavity in front and the pharynx behind. So here is that first pillar that I'm talking about here. Okay, so that's kind of an arch which comes down. It's called the palatoglossal arch because it comes from the soft palate to the tongue. And here, right behind that, this part is the part of the pharynx. Since it's behind the oral cavity, we call it oropharynx. This portion here of the pharynx, which is lying behind the larynx or posterior to the larynx, is known as laryngopharynx. So your entire pharynx is divided into three parts: nasopharynx, oropharynx, and laryngopharynx. The epithelium of these three areas is similar to what would be in the area in front of it. So the epithelium of the nasopharynx would resemble that of the nasal cavity. What would be the epithelium in the nasal cavity? Think of your ANP1. Ciliated, yes, okay. Pseudostratified ciliated, okay? Remember, it had lots of goblet cells. I mean, you know, you produce a lot of phlegm when you have a runny nose, okay? Oral cavity. Oh, my thing is so sensitive. Oral cavity. What is the epithelium of the oral cavity? Remember something called wet epithelium? Yes? It has the word squamous in it. Non-keratinized. Stratified squamous, right? You want a thick layer because you're putting all kinds of things in your mouth at different temperature. So stratified squamous, non-keratinized in the oral cavity. So oropharynx will have the same kind of epithelium. The laryngopharynx also has a stratified squamous, non-keratinized type of epithelium. So laryngopharynx will have the same kind because it's just right behind it, okay? Now in this pharynx, look at this. In the nasopharynx, this here is the opening of the auditory tube. Where my cursor is, that is the opening of the auditory tube, or also known as eustachian tube or pharyngotympanic tube. Right over it, you can see that bulge here. That bulge, under that bulge, is tonsillar tissue, which is known as tubal tonsil. On the posterior aspect, on the posterior wall of the nasopharynx, is this pharyngeal tonsil. So, which is what I said, when you open your mouth, look towards the back, you can see this pharyngeal tonsil actually come down a little bit. It's better seen from the nasal aspect, not so much from the oral aspect. This pharyngeal tonsil, when it is swollen, so when it's extremely large, that's how it will become. That's when it's known as adenoids. And you may have heard of people who, when they breathe through their mouth instead of breathing through their nose, and they, you know, a person may say, oh, that person is a mouth breather. They're not, the child is not growing properly. Usually it is because this pharyngeal tonsil has grown very, very large. You can understand, if it has grown large like this and you're breathing from your mouth, can you see how it's going to be difficult to push air down? So which is why the child opens the mouth and tends to breathe through the mouth. This usually leads to a lot of infections because ideally you should be breathing through your nose so that the cilia in the epithelium can get rid of all particulate matter. If you're breathing through your mouth, you don't humidify the air much, you might breathe all kinds of stuff going inside, making you more prone to infections, which is why the child is sick quite often and may not grow as well, okay? So these two structures are in the nasopharynx. If you look at the oropharynx, lying on either side is the palatine tonsil between those two pillars which I told you about. That's the tonsil which you normally talk about. And then over the posterior aspect of the tongue, and go home today, stick your tongue out and look on the back of the tongue, on the posterior aspect of the tongue, you will see that this area looks very bumpy and ridged. And that's because of tonsillar tissue present deep to it, which is called lingual tonsil. So you can see in the oropharynx you have palatine and lingual tonsil. And then laryngopharynx has no tonsillar tissue. Now, if we put all this together all around like this in a ring, we get the Waldear's ring. The pharyngeal tonsil is on the posterior aspect of the nasopharynx, right at the back. So it is a single type of tonsil up here, pharyngeal tonsil, right on the posterior aspect of the nasopharynx. From here, you move on to the tubal tonsil of one side. So you come to the tubal tonsil of one side. Then come down to the palatine tonsil of the same side. So you come down to palatine tonsil. Then come down in the midline to the lingual tonsil. So here is the lingual tonsil. So lingual and pharyngeal are single. They're only present in the midline. Then from here, go on to the palatine of the other side, back to the tubal of the other side, and back to pharyngeal. So from lingual to palatine of the other side to tubal and back to pharyngeal. So you can see all around your pharynx you have this tonsillar tissue, and it's important because you are breathing in and eating all kinds of food, or breathing in all kinds of pollutants. So you need something to take care of any infection which is like a gateway. So you want to make sure that you take care of infection as far as possible, which is why you have this whole ring, okay? Now, when we look at histology, and I've used palatine tonsil as an example. So these tonsils, as we saw, were present in the naso and oropharynx. All tonsils are covered by epithelium. The epithelium is dependent on where it is present. So if it was in the nasopharynx, it would be like the nasal cavity. If it's in the oropharynx, like the oral cavity. So when we look here at the palatine tonsil, the epithelium is stratified, squamous, non-keratinized. The epithelium gets thrown into little sort of folds like this, which kind of dip down. This is very typical of tonsillar tissue. These little dips are known as crypts. And these crypts actually could be areas where bacteria can lodge, and when neutrophils come to that area, that's where you see pus formation. If you've ever seen someone with very bad strep infection and you're looking at their tonsils, you might see little pus points on their tonsil. Usually it's because of bacterial infection, which has kind of got caught in the crypts, and your neutrophils come and they're taking care of it, and that's why pus is formed in those areas. Under the epithelium, you will find the lymphatic tissue bunched together as round structures, which are known as nodules or follicles. So look at this, bunched together as round structures called follicles, or also known as nodules. So there is no cortex or medulla, as you can see. And in palatine tonsil, if there is if infection was present when that tonsil was removed and made into a slide, you will see that the central area is much lighter staining as compared to the periphery. So just take a look at this nodule up here. Can you see that this central area seems lighter staining as compared to this peripheral area? This lighter staining central area is what is called the germinal center. And what is the germinal center? So these lymphocytes are actually all together like this, forming a nodule. And lymphocytes, remember, we can only see the nucleus. I'm not going to color all of them, but here's a few. Whenever there is infection, what happens is in the central area, we have structures called lymphoblasts. Lymphoblasts usually have a prominent nucleus, but they have a lot more cytoplasm than a regular lymphocyte. So these lymphoblasts begin to multiply and give off more lymphocytes, form more lymphocytes. So in the center, we have lymphoblasts beginning to multiply to form more lymphocytes. Since they have more cytoplasm, therefore the cytoplasm in a lymphocyte or lymphoblast is grayish or light blue in color. So you see the cytoplasm up here, whereas in the periphery where lymphocytes are being pushed off, you don't see the cytoplasm, which is why the central area appears much lighter, because those lymphoblasts are multiplying there. Since you have many lymphoblasts, you can see their cytoplasm, which is lighter staining. That's why a germinal center is much lighter staining, okay, compared to the periphery. So germinal center is a sign that infection occurred, because that tells you that here the lymphoblasts were multiplying and they were giving rise to lymphocytes. This kind of light staining area is not seen in the thymus. Remember I said the thymus does not have germinal centers. So in other words, there is no lymphoblast proliferation and producing germinal centers in the thymus, okay? Tonsil, you can see some features, has epithelium, has crypts, may have germinal centers if there was infection present. So no cortex and no medulla. Okay, it looks like I gave out the answer, but let's see if you were listening to me. How would you differentiate between the tonsil and the thymus histologically? Oh. Okay, well, most of you got it right. Yes, everything holds true. Only the tonsil will show germinal centers is true. But only the tonsil has epithelium and crypts. The thymus doesn't. And only the thymus has a cortex and the medulla. The tonsil doesn't. So all of these statements were true. So that's why the last answer is correct. Okay, let's take a look at this one. Why is the epithelium different in these two regions? Very good. Because of the regions where they are present, they don't all have different functions. They're all part of tonsillar tissue whose function is immune response. And of course, the size doesn't matter. It's because of the region where they are present, which is what I told you. So here again, just to make sure you know where tonsils are present. So where are the tonsils present? So ideally, we should have got 100 on all of these because I just went over everything, right? Okay. In the pharynx, remember I told you they were present in the pharynx. The nasopharynx, you saw that? Behind the nasal cavity. In the oropharynx, behind the oral cavity. I purposely gave you this 1 and 2 just to make sure that you didn't confuse that, okay? They were in the pharynx, so it's number 3 is the correct answer, okay? In the pharynx. It's behind the nasal cavity, behind the oral cavity. So they are not present in that. They are present in the throat or pharynx, okay? Okay, let's look at another question. So here's where you have to think critically. So if the palatine tonsil was enlarged, based on where it is present, what do you think would be the effect? The last one is person would have difficulty swallowing. Very good, yes. Person would have difficulty swallowing. When would a person have pressure on the eustachian tube? If which tonsil was enlarged? Tubal tonsil, tubal, eustachian tube, tubal. And such people usually would be more prone to ear infections because the tubal tonsil, the eustachian tube connects the nasopharynx with the middle ear cavity. Remember from ANP1? So if that connection is gone, middle ear cavity, you know, infections could kind of build up there. And person would have difficulty breathing if they had pharyngeal tonsil problems, right? Because the adenoids on the posterior wall. Let's look next at lymph nodes and ducts. Lymph nodes, as we saw, were distributed throughout the body, but just aggregated in three regions externally, which you can palpate, and a lot of regions close to organs internally. They are connected by lymph vessels, which we'll see. So we have lymph vessels which go to a lymph node, which are known as afferent vessels. You remember when we did ANP1, we did afferent going towards the central nervous system, efferent going away. Same principle holds here. Afferent is going towards a lymph node. Efferent is going away from a lymph node. And we will see that there are more afferents than efferents, and there's a reason why that happens. There are these lymph vessels which connect various lymph nodes, very similar to veins. So you remember veins, you started small, kept building up, and you finally reached large veins like superior vena cava and inferior vena cava. Similarly, lymph vessels from all over the body finally kind of drain into two large ducts. One which drains about 75% of the body, which is known as the thoracic duct, and the other one which drains about 25% of the body, which is called the right lymphatic duct. And you can see the areas which these drain. Instead of memorizing this, I'll show you the picture and you will be able to see which areas the thoracic and right lymphatic ducts drain. In the first slide itself, I asked you, where does lymph finally go? And you remember you saw that image where you saw the lymph draining into veins, right? Because all the blood has to go back into the vascular system. So the lymph, these ducts, the right lymphatic and thoracic duct, they open into veins at the junction where the internal jugular and subclavian form. Remember, they formed what were called brachiocephalic veins, which formed inferior vena cava, and then that went into the right atrium. So they open into veins, and then from there, that finally all that goes into the right atrium of the heart. So let's take a look at this. So up here, let's first look at a lymph node. So when you look at a lymph node, it's bean-shaped, kidney-shaped. So here are lymph vessels which are going towards the lymph node. These are known as afferent lymph vessels. These are lymph vessels which go out of the lymph node. These are called efferent. Notice how many more afferent there are compared to efferent. Also notice that the lymph node has a convex border, and this area where it's concave, this kind of area is indented, and this is known as the hilum. This part is called the hilum of the lymph node. So not only do you have lymph vessels here, you also have blood vessels present. So because lymph nodes also are supplied by blood. So you'll have an artery going in and a vein coming out. So blood vessels present in this hilum. Hilum is always an area you will see from now on when we do the respiratory system, urinary system. It's a way to remember. Hilum is an area where structures enter or leave. And usually the hilum tends to be a bit indented. The lymph node has a thick capsule, very similar to how the thymus was, or even, the tonsil. The capsule sends in septa, which go in and divide it into smaller compartments. This peripheral area of the lymph node is known as the cortex. This central area is called the medulla. Again, the cortex is more darkly staining compared to the medulla, similar to the thymus. Remember, that had a cortex and a medulla, darker staining cortex, lighter staining medulla. But the difference is that in the cortex, in the thymus, remember, it was like a band. Whereas here in the lymph node, in the cortex, instead of being a band of lymphocytes all just collected together, the lymphocytes get aggregated as round structures which are known as nodules or follicles. So you have the cortex consists of dark staining lymph follicles or lymph nodules. If there is an infection, you might find germinal centers in the center of these lymph follicles. Okay? In the medulla is much lighter staining, and the medulla is made up of lymphocytes. Instead of the lymphocytes being aggregated as round structures like this, the lymphocytes in the medulla get aggregated as cord-like, as bundles, long bundles like this. So these are known as medullary cords. And in between these medullary cords, you have spaces which are present, so that the lymphocytes are not very close to each other. They're kind of a bit more dispersed. These spaces which are present are known as medullary sinuses. The word septum the trabeculae is the same as septum. So let's see what happens when lymph actually comes through a lymph node. It's brought in by these lymph vessels, and notice these lymph vessels have valves very similar to a vein. It passes in, travels through these through the cortex, through these follicles. As it's passing through, the follicles get exposed to whatever is present in the lymph. If there's any pathogen that the body recognizes as foreign, then in the center, the lymphoblasts will immediately start multiplying and a germinal center will be formed. Then from there it passes down into the medulla, where it goes into the medullary sinuses, because those are the spaces. It gets in quickly because you have so many lymphatic vessels, but takes time to get out because you have few efferent vessels. So with the result, the lymph stagnates in the lymph node for a while, which is good, because then all these lymphocytes inside are exposed to all that there is in the lymph, which gives them time to react and produce more lymphocytes and antibodies or whatever needs to be done. So that's why you have more afferent vessels than you have efferent vessels. That's the reason behind that, okay? Then up here you can see the nodes where they're aggregated in the cervical region, in the axillary, inguinal, and then out inside in the abdominal cavity along with every organ. All of these lymph vessels drain into lymph nodes, and then they finally drain into either the thoracic duct or into the right lymphatic duct. I told you the thoracic duct drains 75% of the lymph from the body, the right lymphatic drains 25%. So if you look at the thoracic duct and you look at this picture, this is the area of the thoracic duct. All of the left side of the body, the entire left side of the body, and also the right side from the abdomen down to the right lower limb. So that's why so much of the lymph is drained by thoracic duct. Right lymphatic duct is only the right head and neck, right thorax, and right upper limb. So it's only 25%. Okay, so the picture like this kind of shows you which area is drained by which of these ducts. Also notice how these ducts open into the junction between the internal jugular and the subclavian. So they're opening into veins, and that's how the tissue fluid is brought back into the vascular system. This thoracic duct, it begins in the abdomen from a swelling which is called the cisterna chyli. Cistern means a swelling. You all, when you did the brain in ANP1, you remember you did ventricles. Ventricles are also called cisterns. Cistern, just a swelling. Chyle is lymphatic fluid, so this is called cisterna chyli, and this travels, as you can see, it will go like this and then drain all of these areas and finally open into the junction between internal jugular and subclavian. The right lymphatic duct, much smaller, but otherwise it does the same thing. It also opens into the junction between subclavian and internal jugular. Let's take a look at this.
My lower back pain,
Horrible. So excruciating.
it was almost unbearable.
The lymphatic system is part of the body's circulatory and immune systems. It helps to move and drain body fluid and fight infection and diseases. The lymphatic system includes lymph fluid, lymph vessels, and lymph nodes. Lymph fluid is a clear and colorless fluid that contains mainly white blood cells and proteins. Lymph vessels are tube-like structures. The larger lymph vessel on the left side of the body is the thoracic duct. The larger lymph vessel on the right side of the body is the right lymphatic duct. There are also many small lymphatic vessels. Lymph fluid moves through the lymph vessels and carries cells that help fight infection or diseases. Lymph nodes are small oval or bean-shaped structures arranged in groups or chains along lymphatic vessels throughout the body. Lymph nodes help to filter and remove possible harmful substances and to drain the lymph fluid. Every person has a different number of lymph nodes, generally between 500 to 1,500 lymph nodes. The sizes of lymph nodes in each person are also different, between 0.2 of a millimeter, or as small as a sesame seed, to 30 millimeters, about as large as a grape. The thoracic duct collects and drains 75%, or the majority of the body's lymph from the left side of the body, the abdomen, and lower extremities. The lymphatic duct collects and drains the remaining 25% of the body's lymph from the right side of the head and neck, the right arm, and the right thorax. These large lymphatic ducts empty lymph fluid into veins under the collarbones to the heart, where lymph fluid is returned to the bloodstream. About 3 liters of fluid are removed through the lymphatic system every day. When lymph nodes or lymph vessels are damaged or blocked, fluid cannot be drained from body tissues. This causes fluid to build up and may lead to swelling or lymphedema. Lymph fluid only drains when we perform deep breathing that stimulates lymphatic ducts and when we have muscle movements that create muscle milking and pumping action to drain lymph fluid.
This also would explain to you why lymph nodes become important in cancers. Because what happens is when cancer spread from an area, lymph nodes drain a regional area. So imagine if somebody had cancer of the stomach, those cancer cells can kind of seep out because they can go all over the place. So what will happen? They will travel, get into lymph nodes. So they come and they populate this lymph node. This lymph node is sending lymph vessels to another lymph node up here. So it will travel there. So through that, can you see how they can kind of take any route? And so a cancer may begin in the breast, but you might find metastasis in the liver. Or cancer may begin in the liver, but you might find something going up there because of the way these cancer cells can pass in, because lymphatic vessels have lots of spaces in between. They're highly porous, so they can get inside and pass to anywhere of any area of the body. Yeah.
So if the lymph node is kind of filtering things and it's got a lot of the afferent,
Vessels. Right.
It looks like they were kind of interconnected. So then, do the efferent then go to another lymph node after that? And are they
Yes,
like triple
yes.
cleaning as they go?
Yes. So it's not that this lymph node is only connected to one lymph node. You see that? So there may be 3 or 4 lymph nodes connected to another one. So that's why even though 2 efferents come out from here, by the time they reach another lymph node, since it's getting it from other areas, you get more afferents. Do you follow? That's why you have more afferents compared to efferents. Efferents getting out are only 2 from each lymph, 2 or 3, whereas the afferents come from many areas, so that's why they have more afferent vessels.
So if you have metastatic cancer,
It can go to any area. This one is a particular lymph node is going to.
or is it more likely that that metastasis is going to, okay, this one lymph node that's then connected to this other one, then it's
It depends on it depends on the areas the lymph nodes drain into or connected to. So for example, the breast, it's only the lower part of the breast which has lymph connections with the abdomen. So a cancer in the lower part of the breast can spread to the abdomen. A cancer in the upper part of the breast is unlikely to spread, just if you were to look at it hypothetically, because lymph from that drains only into the axillary region. You see? So it depends on what connections the lymph nodes have. Okay, so let's look at this question. If you're watching the video, lymph vessels, as I said, are very similar. So what do you think are the factors responsible for movement of lymph? All of the above. You saw valves were present, so definitely. Remember it mentioned in the video skeletal muscle activity, and when we did the circulatory system, I said venous drainage is dependent on skeletal muscle activity. Similarly, especially for lymph from the lower part of the body, you need skeletal muscle activity. That video also mentioned thoracic pressure, and also when we did venous drainage in the veins, thoracic inspiration kind of sucks up the blood. And remember, veins were always present next to arteries, and the pulsations of arteries tend to kind of transmit to the veins and help that. Same thing happens with lymphatic vessels. Large lymphatic vessels tend to lie close to the artery. So thoracic duct, for example, lies very close to the aorta. So aortic pulsations help to kind of send the lymph up, okay? Okay, if the big toe was swollen, which areas do you think would be affected? Very good. Okay, you all got this one right. The first time we got 100. Okay, good job. Let's see this one. Okay, well, so I'll take 70%. Remember, lymph flows towards the heart. Thoracic duct opened into the junction between internal jugular and subclavian veins. Those are present in the thorax, or not even thorax, they're going into the neck. So lymph has to flow from the abdomen into the thorax. Lymph has to flow upwards like this, and then only it can kind of drain into this area, okay? So that's why looking at these images is very important. You must think critically in these kind of questions. Next are lymph nodules or lymph follicles, just follicles which are part of another organ. So they are found in the walls of the organ, usually in what is called the lamina propria or submucosa. Especially seen in organs which are exposed to the exterior. In other words, it doesn't necessarily have to be exterior like skin, but your mouth, for example, oral cavity exposed, goes inside. Your nasal cavity all the way down into your, right up to trachea and bronchi, because, air passes all the way down there, so pathogens can go in. Urinary tract, because it finally opens to the outside, so infection could pass through. So you see this is a piece of small intestine. If you looked at it just like that in a gross view, you can see these little kind of bumps. These are the Peyer's patches. And here, if you take a section, this part here is part of the lamina propria. Here is muscle tissue. And here is the lymph follicle, which is present, rather large. And here you can see that there is a germinal center. So look at this darker staining periphery and lighter staining center. Very well defined germinal center up here. Only in the small intestine, it's called, these follicles have a special name and they are known as Peyer's patches. Elsewhere, they're just known as lymph follicles. So in which of the following areas would you not find lymph nodules as part of their structure? Epidermis, very good. Remember, I said if a tissue, I just told you, if a tissue is exposed to the outside, and I gave you these examples, it would have lymph follicles in its wall. Second, a tissue has to have a blood supply in order to have lymph nodes. If there is, epidermis is epithelium. Epithelium is avascular, like cartilage, right? So it will not have it won't have, and there was no point having lymph nodes inside and lymph follicles inside, and which are going to be connected by lymph vessels. Lastly, the spleen, largest lymphatic organ. This is present in the left hypochondrium. So remember the 9 regions, it's present in the left hypochondrium. It kind of lies obliquely, and it's related to the 7th to the 9th ribs. Since it's on the left side, the left pleura and the diaphragm. And many organs, as you can see here. So here's the spleen, here's the stomach related to the spleen, the left kidney is related to the spleen. Look at this, left suprarenal gland is related to the spleen. This organ here is the pancreas. This part here is called the tail of the pancreas. The tail is the part which has the most of the endocrine part of the gland. So tail of the pancreas related to the spleen. So you can see a bunch of structures, small intestine, and even the large intestine is related, large intestine up here and loops of small intestine. So many organs related to the spleen. So if ever there's a splenic injury, you can see that any of these organs could be affected. Its function is it filters blood and it removes the dying red blood cells and then sends back the iron and the protein back, hemoglobin, from the hemoglobin, the iron and the globin molecule back into circulation. So it's often called the graveyard for red blood cells. It is entirely covered by peritoneum. Normally you cannot palpate it, that means you cannot feel it, it's lying under the costal margin. It has to enlarge twice, it has to become double its size in order for it to be visible outside and for you to be able to palpate it, okay? So it has to enlarge so much.
What's the cause of enlargement?
What is the cause of enlargement? Usually it could be something known as portal hypertension. One of the causes, remember how the splenic vein and the superior mesenteric vein form the portal vein? So if the liver is damaged, splenic vein can't drain to it, so spleen will enlarge. Tropical countries, there are certain parasitic infections called Kala-Azar is one where the spleen can be enlarged in that case. Certain types of leukemia, spleen can be enlarged. You can remove the spleen because when it gets torn, it is so vascular that you cannot really sew it up, you can't stitch it. You can remove the spleen, the person doesn't really have too many complications after removal. In the beginning, maybe a little bit delayed immune response and so on, but after that they are fine. Okay, the other organs take care of it. So when you look at splenic histology, spleen has a very thick capsule. What is not seen here is the capsule is not visible because this is just taken from a central part of the spleen, but if you looked at the spleen like this, very thick capsule covering it, and the capsule sends in thick septae inside. So this is a septum which is seen, which is really small, but usually you'll see very thick septa which look pink, and in the septa you'll see blood vessels because that's how blood supply reaches the inside of the spleen. There is no cortex or medulla. Instead you see a red and blue appearance. What you see is a lot of lymphocytes bunch up together to form round nodules or follicles. This, you can see one follicle here, another one here. This follicle has a special name in the spleen. It's called white pulp. So these are scattered. It's called white pulp since it's made up of white blood cells, okay? So this is white pulp. And then around the white pulp is a general reddish appearance. This is called red pulp because it has free red blood cells which have leaked out of the blood vessels, macrophages, lymphocytes, so they all spread around like that. Because of the red blood cells, it gives a reddish appearance. So this is called red pulp. So very typical of the spleen. Thick septa, red pulp, which is red blood cells, macrophages, lymphocytes, and white pulp, which is an aggregation of the lymphocytes and macrophages in the form of nodules. And there's no regular order, it's all kind of randomly scattered around, okay? Here's an image, although spleen is related to the 9th to the 11th rib. I think the slide before said 7th to the 9th. Just make a correction. And I think I may have mistakenly, I knew I was saying it wrong. 9th to the 11th ribs, not 7th to 9th. So just make a correction there. Ninth to the 11th ribs. Okay, don't answer this one. So here you can see splenic injuries are quite common, especially if the spleen is enlarged for any reason. You know, many years ago there was a football player by the name of Sims. Do you remember him? He had a splenic injury. I forget whether he was a football or a hockey player, but anything, you know, which any injury on this left side up here with hit hard or a stab wound can kind of pierce through and can injure the spleen. So you can see up here. And so based on this injury, which do you think, based on its relationship to various organs, which is least likely to be injured? Which organ is least likely to be injured? So I showed you that picture and all those organs. just so that to make sure that you kind of look at images carefully. I'm kind of making sure you follow your PowerPoint images and look at them, look at every label very, very carefully. Very good. Duodenum, that's least likely to be injured. And again, if we look at this, here's why it's important to look at these pictures. And if you look here, so here's the stomach, the pancreas, left kidney, here's the duodenum. So look at this part here, so far away. So the spleen is injured here, the duodenum is not likely to be injured, okay? So please do make sure that you are looking at these images carefully. Okay, let's just do a quick review. Which of the following would be typical of thymic histology? So here the operative word is typical. Okay. The correct answer is, I said the operative word was typical. The correct answer is presence of pink onion skin-like structures which are called Hassel's corpuscles. Why is cortex and medulla not typical? Because you see cortex and medulla in the lymph node as well, remember? But you do not see Hassel's corpuscles in the lymph node. You see it only in the thymus. So therefore, it's typical of the thymus. Epithelium is typical of tonsils. Red pulp is typical of spleen. Let's look at this. You're looking at a slide of a lymph node. So let me see if you were listening. How would you be able to tell that there was an infection? Ooh, I was hoping no one would say pus oozing out. You're looking at a slide. See the word? Looking at a slide under the microscope. You cannot see pus oozing out in a slide, right? So it has, the germinal centers are what kind of tell you that, you know, there was an infection over here. I was hoping no one would say this. This I could still kind of take it, but okay. So please do, this is how you have to read every word very, very carefully. Pick and choose what operative words are, what the clues are given, and then, you know, based on that you answer your question.